We had this void of space where a lot of patients were falling in where they weren't quite bad enough to do a joint replacement or a major surgery, but they weren't responding to traditional therapies like anti-inflammatories, steroid shots, or physical therapy or whatever. And it was frustrating as a practitioner to be in that space. So myself and a lot of colleagues began working with the patient's own blood and utilizing the patient's own innate healing mechanisms to try to drive repair in a tissue, for example, that may have a poor blood supply or may not have a very good innate healing capacity. From a safety perspective, it was very important because we're using only the patient's tissue. There's no tissue from outside, another patient's tissue or another donor tissue. It's your tissue. We're just putting it to work for you in ways that your body wouldn't do under normal circumstances. And that's been incredibly exciting to fill that void that I described of patients that were stuck in the middle, and we really didn't have a lot of great options for them. Once we have our target, our diagnosis, right, now we're starting to think of, okay, how can we work with the body to facilitate that tissue to go on to heal or repair? A lot of people consider repetitive injuries like tendinitis, for example, as incompletely healed injuries. Well, we want to give that tissue the building blocks to fix itself. So we do an assessment, we plan out our biologic strategy, and then do extensive counseling with the patients regarding what they can expect in terms of the procedure itself, the post-operative rehab and activity restriction protocols, pain control, all of those things. So a lot of education going into before we even touch that patient procedurally. In terms of the procedure itself, these are relatively straightforward procedures that can be done in an outpatient setting with local or some oral anesthesia, depending on the situation, and can take anywhere from 15 minutes to an hour to perform, depending on what and how much we're targeting. From a non-surgical perspective, they're typically injection procedures, so a knee or a shoulder or a hip or a tendon or a ligament that we're targeting. They're typically guided procedures, so we'll use fluoroscopic or ultrasound localization to improve our accuracy and safety. And then procedures done, patients typically monitored anywhere from 15 to 20 minutes and then discharged home. The limitations to activity after a majority of the procedures are pretty minimal. This will vary a little bit from practitioner to practitioner, but I personally allow weight bearing immediately. We don't immobilize tissues for the most part after these treatments. We like to get them going. And there may be some athletic or exercise restrictions, but you're allowed to get back to your day-to-day almost right away. So it makes them very attractive in that respect. Pain-wise, relatively low. You can have a couple of days of soreness depending on the target tissue and how aggressively we're going after that tissue from a biologics perspective. It's not 6 weeks of soreness. It's usually measured in a matter of days. And the downtime from work, for example, or from exercise or from whatever, is fairly limited if you compare it to like a surgery. Right? Surgery will always have an important role, and surgery is in many cases very appropriate. What we try to gauge when we're evaluating a patient is, well, we like the idea of helping the body fix itself, but can we do that non-surgically, or do we need to do that as a part of surgery? So the point of regenerative medicine isn't to replace surgery. The point of regenerative medicine is to provide a treatment paradigm whereby we can facilitate the outcome no matter what, whether it's surgical or non-surgical. And that's what's incredibly exciting about the versatility of these types of therapies. So it's so important to emphasize that early in the regenerative medicine paradigm, perhaps we didn't fully understand the mechanisms. We're continuing to get better at understanding the science behind how this is working, and in doing so, it's only going to allow us to alter and adjust these therapies to make them more clinically effective and safe. And to the safety point, I should add, thus far, in many thousands of platelet-rich plasma and bone marrow concentrate procedures, there's been no serious reported events in the literature. For the most part, our risk is minimal, and we counsel the patients extensively on that. You can't reject your own body's tissues, so that's fairly comforting from a safety perspective. The only real risk is infection or a bad implantation, Obviously, there's a lot of training that goes behind doing these procedures, but from a safety perspective, we're very strong, and the field continues to track those measures, and thus far we've been in pretty good shape there. So research continues in this area very actively, and the question I get is, so can you regrow my cartilage, for example, in an arthritis situation? And the research, and we have our veterinary colleagues really to credit for a lot of the early work that went into this, suggests that we can to a degree. Now there are some limitations in just how far we can take that process. But in addition to the regeneration aspects of these therapies, there's also a pain relieving aspect of the therapies, which we're also continuing to understand as we go. And these cells modulate inflammation very effectively. So if you're not making inflammation in an arthritic joint, it's going to hurt less. So you kind of have the best of both worlds, where yes, we can repair tissue or regenerate tissue to a degree, but we can also subjectively make that patient feel better simply by controlling the pathologic inflammation or the bad inflammation that's occurring within that particular tissue.